In fact, this is to be the last webinar that we have scheduled for 2014, and so we really believe that you're in for a treat today. You can see the slide on the screen which outlines the agenda for today. I'm going to start off with some context-setting remarks. Then we'll move to Dr. James Busch from Wyoming, who's going to talk to us about what they're doing in Wyoming around oversight and monitoring of psychotropic medications. We'll follow Dr. Busch's presentation with a question and answer period. Then we will move to our colleagues, Dr. Dos Reis and Dr. Reeves in Maryland, to talk to us about their pre-authorization program there, and we will follow that with a question and answer. What's not noted on this slide is a conversation that we'll have following that last Q&A, where we want to share some technical assistance resources with you, both that have been developed for the virtual learning community and our 6 PMQIC states. Those of you who've been with us before know that we're leading a 6-state collaborative supported by the Casey Foundation, Psychotropic Medication Quality Improvement Collaborative, or PMQIC. And we're also going to invite Dr. Christopher Belanci to share some technical assistance resources that are being supported by SAMHSA and the TA network. And I'm not going to steal any of Christopher's thunder, so that's a little teaser for that one. Next slide, please. So just to set the context, what are red flags? We pulled this from a report by Dr. Laurel Leslie and her colleagues at Tufts. Basically, red flags are markers that are used within various child-serving systems, agencies, and health plans to identify cases in which preliminary or high-level data might suggest that the medications and prescribing patterns that are in place may not be appropriate. I'm going to pause for a moment. I'm hearing some background noise, so if anyone who has access to the line right now could please put their phone on mute, that would be great. Moving to the next slide. Travis, thank you. Why are red flags important? So one of the things we know is that psychotropic medications are strong medications, and they have side effects. And so safety is a primary concern. The red flags also enable the state agency that's overseeing and monitoring use to trigger a case review. So to actually look into the case of that particular child and determine whether or not the prescribing pattern that they're seeing is actually appropriate. It also suggests when lab work might be required. So certainly there are some psychotropic medications that have metabolic impacts. And so we want to make sure that when those are being used, that we have appropriate lab work being completed for those children and at a periodicity that is appropriate to the medication being used. With regard to prior authorization, and again, we'll hear a little bit more about that from our colleagues in Maryland, red flags are often used to trigger that prior authorization process. Certainly quality assurance and outlier identification are related. If we have a peer-reviewed type of process for what is an agreed-upon acceptable use of the medications, when we see something that's outside of those parameters, we want to be sure that quality care is being provided. Next slide, please, Travis. So in 2012, the Administration for Children and Families issued an information memorandum, and that memorandum outlined 3 aspects of potentially outlier prescribing practices: too many, too much, and too young. And what you see on this slide are some operational definitions for those 3 types of outlier prescribing patterns. I'm not going to read that to you. You do have that as a resource, and if you are interested in that full information memoranda, the details for it are over in that top right box, and so you can certainly access that online and read the full memoranda. The one thing we would point out is, as it relates to too young, there was not a specific minimum age that was listed in the information memoranda, but it was certainly recognized that young children are specifically and particularly vulnerable to side effects that can result from the use of psychotropic medications. And in the context of our PMQIC, or our Psychotropic Medication Quality Improvement Collaborative, our data subgroup identified too young for the purposes of our 6 states as children under age 6. Certainly other states use lower age ranges, but for the purposes of our work, we identified age 6 and below to be too young. Next slide, please. One of the other things we know about red flags is that they vary by state. Some states use different policy mechanisms to put those red flags in place, regulations, or other practices. Some states use prospective and other states retrospective approaches. And the other thing we'd say is that there's no one set of red flags other than those specified in the federal guidance from ACF. We had a survey that we did of all 50 states, and one of the things that we saw in that survey is that there's a wide range in terms of how many red flags a state might choose to monitor. Some have just a few, so maybe 3. Others have, north of 5, close to 10. And so the main point there is that whatever red flags are in place, they need to be able to be monitored regularly, or you kind of undercut the purpose of the process. And the other thing we would say about red flags, and these on the slide being some of the more common ones, is that they are, again, not always operationally defined exactly the same way across states. So age is an example. I mentioned that for our 6-state collaborative, we defined too young as being under age 6, whereas other states have defined that as an even younger age group. So with that, I'd like to feel like that I've given you a little bit of a context for today's presentation, because I want to really have the bulk of our time available for you to hear directly from our speakers and to engage them in a question and answer period. So with that, I'm going to turn to our presenters. I'm going to first introduce Dr. James Busch. Dr. Busch joined the Wyoming Department of Health in 2007, and he serves as its Medicaid Medical Director. He has a particular interest in medical policy and organization and has filled many roles, including Chief of Staff, President of the Colorado Society of Internal Medicine, and President of the Fort Collins IPA. Dr. Busch has been on the clinical faculty of the University of Colorado for more than 20 years and has also taught residents in family practice in Fort Collins. So with that, I'm going to turn to Dr. Busch.
Thank you very much for the invitation and the opportunity to speak to this group. I do appreciate it. Next slide, please. Shortly after coming to the Wyoming Department of Health, we had been noticing that Wyoming had been having an increasing problem with more children entering foster care and the mental health systems at higher costs than we had ever seen before. And from 2008 to 2010, we had noted a 54% increase in psychiatric residential treatment facility bed days. We had been having significant difficulty arranging for evaluations of children with trained professionals prior to foster care placement. At that time, we had 6 child adolescent psychiatrists serving the entire state. And in context, those numbers have worsened. We are now down to 3 child psychiatrists in the state of Wyoming in this time. So and we only have 26 total psychiatrists in the entire state of Wyoming. And so care is often being provided by primary care physicians. And so because we were having more children in foster care and in residential placements on drugs at higher doses and at younger ages, our physicians advisory group expressed this to us as a major concern. And in the next slide, we did a baseline needs assessment. And it was always very important to establish a baseline. Now, recalling that Wyoming only has fewer than 1,000 physicians total, we have about 300 primary care doctors, and we got a return of 101 out of those 300 primary care physicians responded to a statewide survey. 62% felt they could not meet the mental health needs of their pediatric patients. 69% felt they could not consult with a mental health specialist in a reasonable length of time. 66% felt their patients got good mental health less than half the time, and only 78% felt that less than half the time they could accurately diagnose behavioral health problems. That was just a recipe for disaster. Even the physicians were openly acknowledging that the patients were not getting adequate care, and medications and residential placements were going up and up because of that. So next slide, please. This is maybe unlike a little bit your other states. Our entire state is a psychiatric professional shortage area. So we felt we had to do more than just put prior authorizations on. So we wanted to come up with a comprehensive solution. We wanted to provide timely and appropriate screenings for psychiatric evaluations, diagnosis, and treatment recommendations for all children prior to entering the juvenile justice system. And the first step of that is multidisciplinary team hearing. When we were doing this review, we discovered that there has been no physician who had seen the child prior to their placement in a psychiatric residential treatment facility. We wanted to provide mandatory reviews of those children who had been prescribed doses of psychotropic medications beyond the standards set up by our Office of Pharmacy Services. We also wanted to provide elective consultation and education in collaboration with our primary care provider, providing services to Medicaid eligible children through our provider assistance line. So in the next on the next slide, we're going to delve more into our the process for our second opinions, our red flags. The slide that will follow that will show us the steps so you all would be able to reproduce them in your states. And then I'll go back and I'll touch on the MDT hearings and the elective consultations, and then I'll share our results. So as we have said in the introduction, the red flags we set were developed in collaboration actually with Washington State and then vetted through our Physicians Advisory and Pharmacy and Therapeutics Committee. And we settled on, for too young, we said children 5 or under who were receiving an antipsychotic or ADHD medication with an absence of DSM-IV diagnosis and claims history, or the prescribed psychotropic medication is not consistent with appropriate care. Too high a dose, we settled on 150% of maximum FDA dose by age. For if they had more than one prescription in a therapeutic class or 5 or more psychotropic medications prescribed concomitantly after 60 days, or 2 or more concomitant psychotropic, antipsychotic, or ADHD medications after 60 days. The 60 days was important because we didn't want to get those who were tapering, but that did introduce some technical problems that we'll address. So in our next slide. So the way Wyoming handles this is our pharmacy benefits manager will pull reports on all of the psychotropic medications prescribed to children quarterly and sends them to our pharmacy technician. The pharmacy technician will then easily and quickly identify all those who exceed the too young or too much parameters. But because of that 60-day overlap, she has to review all those who exceed too many to rule out tapering doses and medication changes. All those cases that she identifies as exceeding our too many, too much, too young parameters are then referred to Seattle Children's Hospital, where we have a contract with the child psychiatry department there. After that consultation, the pharmacy technician will pull what we have in our state is a continuity of care document, which shows all current medications, procedures, encounters every month to ensure that those recommendations by the Seattle Children's Hospital are being followed. That was a step that we had to learn to do, is to get that follow-up and make sure it was accurate. Next slide. So what sort of consults were obtained over the years 2011 to 2013? We had 631 mandatory consults from over that time period. We had 277 elective consult calls to that Powerline, and I'll go into more detail on that later. We had 125 mandatory second opinions, and we had 229 multidisciplinary team consults. Next slide. In terms of our mandatory second opinions, 60% of those were for the greater than 150% of the maximum FDA dosing, 37% were for being too young, 3% were polypharmacy. The sort of physicians who were being reviewed, 48% were psychiatrists, 40% were primary care physicians, 6% were psychiatric nurse practitioners, and 6% were other medical specialists, because in Wyoming you often will have even other specialists having to assume primary care for a lot of our patients. So what did the patients look like? Next slide. This again breaks them down into the columns showing the elective telephonic consultations, the foster care MDT televideo consultations, or the mandatory second opinions. Again, you see the total numbers, you see the breakdowns, typically a few more male, about 60% male, or 65% male to 35% female. You again see the breakdown for on how many were on psychotropic medications. It was interesting, only 63% were on psychotropic medications at the time that they were calling electively for the PAL consultations. So we're hoping that those were preventing children having to go on to psychotropic medications. You can see the CGAS score means in the mid to low 40s, history of foster home placement, and a history of a psychiatrist or psychiatric nurse practitioner, PA, having seen them. And interestingly enough, again, you only see 18% had the ability to see a psychiatrist before the PAL line, so that was really filling a gap. Next slide. To explain a little bit more about what the PAL line is, this was something that was developed first for Washington State. It's a provider assistance line, and it's to support the primary care physicians or physician extenders. It's a toll-free call to the Seattle Children's Hospital. The calls are typically called back within the same day. Most times they can call and immediately be connected to a child psychiatrist. It's available 9 to 6 Mountain Times, which is 8 to 5 Pacific Time, but that is an advantage because now the physicians can call at the end of their regular office hours. We did not make it mandatory for them to talk about Medicaid children. We said you can call any child. This is an educational service. They get consistent evidence-based advice, and they have a written follow-up that is available to them within 24 hours. Next slide, please. That is what separates this from just a curbside consult, because the physician now has a written recommendation he can attach to the patient's chart, or he can throw away, whatever he wants to do. If the questions remain after discussing a Medicaid client, they can even go to the next step, which is a full televideo consultation. We also put together a web page with resources, and you see the web page there, which includes a sort of primer or manual on the standard of care for physicians providing care to children with psychiatric issues. That's been a very popular web page and gets a lot of traffic. Next slide. The next slide demonstrates who has been using the PAL, and again, 77% were the primary care providers as we expected, but what we didn't expect was that 7.5% of the time, those were the psychiatrists who were feeling very isolated. Remember, there's only 3 child psychiatrists, 25 total psychiatrists. They would call the PAL line to get consultations on the difficult cases. 7.5% were psychiatric nurse practitioners. 4% were mental health therapists, because we decided why not open the line up. And I think the 4% were people like myself who are within the Department of Health, who were calling for other reasons. Sometimes we even had some cases just drop by us here at the Medicaid office, and I would call the PAL line for help, and we've actually averted 2 hospitalizations by my calling the PAL line from a client who walked into here. The next slide shows some of the outcomes, excuse me. Again, there of the 277 consultations, the global assessment score was 47. Only 59% were Medicaid clients, so 41% were non-Medicaid clients, but that is fine with us. We're happy to pay for them. There were 170 recommendations on medication regimens. 27% of the time was to start a certain medication, 16% of the time to stop a medication, but 84% of non-medication intervention. So it's not just how do we reduce medications, we're trying to optimize medications. Next slide. Turning to the second half of the puzzle is the MDT evaluations, and that stands again for Multidisciplinary Team Evaluation, and that's what's being done. The multidisciplinary team is the first step in before a child goes into state custody. Every county has a site where an MDT evaluation can be performed and with televideo equipment. We again didn't want to mandate that they had to use our Seattle psychiatrists for this. In some counties where they have child psychiatrists, we will accept any child psychiatrist. But the trouble was they weren't timely. These cases are typically scheduled and performed within 3 days, and a written evaluation is back within another 3 days. So essentially within almost 1 working week, you have a child psychiatrist report in hand. This is very important because they don't tell the court what to do. They just make a recommendation that the court can then follow. Why we broke it down into routine or urgent. At this point, every case has been done essentially within 72 hours. Next slide. So what are the age ranges? 72% of them are between 13 and 18. 27% were younger at 6 to 12. 31% were living at home. 21% were already in a crisis center. 18% were in foster care or a foster home. 17% were already in the juvenile justice system. And 6.5% were in a RTC, residential treatment center, which is a step down from the psychiatric residential treatment facility. So they were all over the spectrum already in terms of placement prior to the MDT. Next slide shows some of the diagnoses. The majority of clients had, or the average client had at least 3 average diagnoses per review. 52% were disruptive disorder, 44% depression, 39% attention deficit hyperactivity disorder, 36% post-traumatic stress disorder, and 28% anxiety. Not only were there an average of 3 diagnoses per client, there was an average of 3 recommendations per consult provided by the child psychiatrist. Next slide. So, next slide, please. Is my screen frozen? There. I think we went 2 slides. Sorry. There you go. So what were the outcomes from all this? In terms of our Medicaid psychiatric medication utilizers, you can see that for all, the first column shows all Medicaid psychotropic utilizers. The next column shows our utilizers for too young. The next one for those who exceeded the 150%. And the last column shows the utilizers with too many. You can see that we're running just a little over 9% are on some form of psychotropic medication. But the numbers who were too young fell from 218 or 4% to 126 or 2.28%. Those who had a dose that was too high fell from 137 or 2.51% to 66, just a little over 1%. The too many were a lot smaller number, only 34 or 0.62, falling to only 29 or 0.52. So that one did not reach statistical significance. But another more graphic way to look at these numbers, next slide. You can see these are the same numbers just graphed out to show on the top of the solid column the too young, and the dotted line is the too much, and then the dashed line is the too many. Next slide, please. So the state has calculated we have a total cost savings of almost $3,000 per child over 6 months. This is a combination not only of the medications, but also in the fact that we've reduced the number of children admitted to PRTFs, and we've reduced the length of stay in the PRTFs. So 87 children yielded a total savings of almost $2.5 million. And so after counting all the costs of the program, we had a 1.8% return on investment was achieved, not including the pharmaceutical costs. So what were the lessons that we learned in this? It was a very complicated problem, compounding wide distances, inadequate number of providers, we felt to just approach one aspect was not going to be sufficient, so we had to try several approaches at once. Before we started, we identified as many barriers as we could to improved care. The biggest lesson we did a mid-course correction on was to check back on the cases to ensure compliance, and I can't emphasize that too much. The other element was to educate everyone repeatedly. We had resistance from people at first who didn't understand that this purpose wasn't to point fingers or criticize, but to educate and offer resources that were lacking within the state. And then over the course of time, things have improved significantly. And what we've noted going on from this is that almost any case that comes in now that exceeds our too many, too much, too young parameters is from a new physician who has just entered the state or a child who went out of state and had prescriptions. So the physicians have altered their prescribing patterns, and it does seem to be sustaining long term. And next slide. I am happy to help and talk to anyone who wants more details of how we did this program. And thank you very much for your attention.
Thank you so much, Dr. Busch. So now what we would like to do is turn to our question and answer period. There is a question and answer feature on the right side of your screen. If you'd like to pose a question to Dr. Busch, please use that to submit your question. In the meantime, Dr. Busch, I think we do have one question that we'd like to pose. You talked about the process through which the pharmacy technician pulls a continuity of care document for the monthly review. What do you do if the recommendations of the Seattle Children's Hospital are not followed?
That always now prompts a phone call, initially from the pharmacy tech saying, are there any problems? And if that doesn't yield a satisfactory answer, then it gets a call from me. And the CCD viewer is a wonderful little tool because it doesn't matter which EHR you're on. As soon as you register, all you need is internet access. You enter the patient's name, date of birth, and Medicaid number, and you can get that CCD, and we're using it a lot now for all of our internal reviews because now you don't have to always call for clinical records.
Great. Another question for you. Well, you talked a little bit about the MDT evaluations. Can you just say a little bit more about how you have a backup to that given the limited number of providers, of child and adolescent psychiatrists in particular?
Sure. And with the MDT, the key element was that because we only had 3 child psychiatrists in the state, we knew we had to go out of state. And that's where, again, the majority of these, I would say 98% of them, are now being done via telehealth with our Seattle child psychiatrists. So they go to the Department of Family Services is the one who, when they know the child is going to be going to a MDT hearing, they schedule directly with Washington, and that evaluation is performed actually in the DFS office, the Department of Family Services office, which every county has one with the proper equipment in it.
Thank you. One more question before we move on. As a request, Dr. Busch, whether or not you have a sample of the continuity of care document that you can share.
Yes, as a matter of fact, there's a web page that talks, it's part of our total health record, and you can actually watch a video of it, which gives live screenshots on how to register and everything, but of course any other state could probably do something very similar. And that is at www.wyomingthr.com. So just the word Wyoming, T like total, H like health, R like record, totalhealthrecord.com. And there's a little link in there that says to learn more about the CCD. You click on that and you'll see a video presentation walking you through it.
Wonderful. Thank you. Okay, so we are going to shift gears now, and we're going to move to our colleagues in Maryland, Dr. Susan Dos-Reyes and Dr. Gloria Reeves.
Okay, so thank you so much for the invitation to come and speak today. Susan and I are on the faculty here at University of Maryland in the School of Medicine and School of Pharmacy in Baltimore, and we're delighted to speak today for two reasons. One is this will help us overcome our recent loss of our beloved Baltimore Orioles in the playoffs yesterday that we're still mourning over. But more importantly, certainly Susan and I and the team that we've worked with have really benefited from dialogue with other states and the ongoing exchange of information. I think we're all in a process of figuring out how to set these kind of systems up and learning from each other. So we're very pleased to be able to share a little bit our experiences on behalf of our teams that we work with in appreciation for the help we've received from other states and in hopes that we can all learn from each other. So next slide, please. We have two main objectives for this talk. The first half of the talk, I will be presenting on a Maryland Medicaid program. It's called the Peer Review Program, and it's an antipsychotic medicine pre-authorization program for Medicaid-insured youth under the age of 18. So the first half, we'll really talk about how we developed the program, our process of establishing red flags, and some lessons learned from implementing those red flags. And then the second half of the program, Susan is going to talk, since we're both academic types, she's going to talk about this work in the context of work going on at our universities to really think about complementary work focused on specific vulnerable populations. So she'll talk about outcomes in the foster care population, as well as thinking about how to engage consumers in really improving safe and appropriate care. Next slide, please. So I'm just going to start out with a slide that reviews the FDA approvals for pediatric antipsychotic treatment. And I show this slide to really reflect on two things. One is, for those of us who trained over 10 years ago, it's really wonderful to see that pediatric research has expanded to the point that we do have some evidence base and knowledge about risks and benefits of these medications for specific causes. The balancing viewpoint of the slide, though, is that most of the kids who are prescribed this medication, both in our state and nationally, are really being prescribed for off-label treatment, and that is for severe problems with aggression, irritability, so behavior and mood problems that don't fit into these categories. So I think it's important in the context to keep in mind that we know less about both the risks and benefits of using medicines once we veer outside of these bounds. Next slide, please. So we talked about the too young, too much guidelines. We think of things, very simply here in Baltimore. We just think about two major questions. One is treatment safe? So that's really at a very basic level. We have a lot of concerns about antipsychotic medication side effects. Part of the reason that Medicaid had contacted the academic centers to get some input on this program was because of all the data that was coming out about safety concerns. We know that kids under the age of 5, 100% of treatment is off-label, so we know less about safety tolerability issues in those children. We also know that there's an unfortunate trend in medicine to use the latest and greatest that's out there. So we also were aware of trends where sometimes children were being prescribed medicines that had not received any kind of pediatric FDA approval before they've been tried on any first-line agents or agents that we know about. And then finally, we know that unfortunately, from both our state data and national data, that side effect monitoring had been quite low. So it's really difficult to get blood draws done in kids once, let alone follow-up blood draws. So we have a lot of empathy for the situation of providers and parents in really getting appropriate safety monitoring, but we have concerns about kids being on these medications for long periods of time over development without really knowing what's their risk-to-benefit ratio. And then the second question is really about, is treatment appropriate? And that is really the challenge of figuring out how to think about the majority of treatment, which is really largely off-label. So we have feedback from providers, from parents that tell us that kids who have severe aggression can be certainly not just safety concerns, but kids who don't do well at school academically, they have difficulty with relationships at home and school. So we want to figure out what's an appropriate threshold for off-label use. And then we also have concerns about certainly recent increases in antipsychotic prescribing and really trying to understand that, as well as disparities between Medicaid-insured use and private-insured use. Next slide, please. So the goals of the program, basic goals but important ones, and that's overall to improve safe and appropriate antipsychotic prescribing to youth. Part of the goal of the program was really to use this as an opportunity to develop an oversight and monitoring program that is prescriber blind, and by that I mean we have the same guidelines and requirements for individuals who are primary care providers versus mental health providers, with the general goal that their needs may be different for a program like this, but that we can offer things that can improve either safety or appropriate prescribing. And an added benefit, similar to the information we learned about from the Wyoming program, is it really does establish a great opportunity for dissemination of information, emerging information on new medications, side effects, dosing, and other things. So we view this really as a great opportunity for education and outreach. Next slide, please. So our process, similar to the program in Wyoming, really starts with the prescriber submitting information that's going to be reviewed by a pharmacist. So the way it works is if you're a provider in Maryland and you're treating a child with Medicaid insurance and they're under 18 and you want to start an antipsychotic medicine, you can submit that request either by phone or by submitting in a pretty simple checkbox 2-page form. And the web link that gives you access to that information is available at the bottom of the slide. So a provider can phone in or fax in a request anytime during business hours, Monday through Friday. And the first level of review is by a pharmacist. And so that review, the oversight for that review are done by pharmacists who have specialized training in psychiatry. And they have a protocol they follow where either the medication is approved or there's an issue that is flagged for review by a child psychiatrist. A child psychiatrist does a peer-to-peer review with the prescriber. That's done by phone. And in most cases, we're able to establish some consensus about a plan with the medication regarding approval. But there is another level of reconsideration by a child psychiatrist at Medicaid if that's requested by the provider, if that's available to them. Next slide, please. Oh, and I didn't mention the authorization can be, right now, currently we can authorize up to 6 months, but there is an ongoing authorization process. And just to echo the comments that were made in the presentation earlier, that we do agree it's very important for the ongoing monitoring to really check in and see if issues are getting addressed over time, such as concerns about high doses or polypharmacy. Next slide, please. The review criteria, when you look on the form, you can really boil it down to 4 different areas. So we collect information on the indication for treatment. So that includes information on target symptoms and diagnoses. The medication regimen, that's where we can look at things, concerns related to starting dose, polypharmacy. Sometimes we get referrals for kids who are prescribed 2 or even 3 antipsychotic medicines. We can look from our database system if there are lapses in the medication getting approved, so we can let a provider know that information. We also spend a considerable amount of time reviewing safety data, so information on labs, monitoring height and weight. When we first started the program, we were surprised that a lot of mental health providers did not have a way of measuring height in their office. So some of this was really helping providers set up an opportunity where they can do adequate safety monitoring. And finally, again, to underscore comments made in the presentation earlier, we do ask providers about non-medication treatments, and we can be a resource to help with therapy referrals. Next slide, please. The peer consultation, the contact between the child psychiatrist and the prescriber, is set up to be very collaborative, problem-solving review. Outright denials are quite rare, and we really try to avoid anything that involves any concern about abrupt discontinuation of medication. We try to work with providers and get some consensus about a time frame to establish changes. Next slide, please. I just wanted to highlight some lessons learned from our implementation process, and Susan's going to follow up with some information specific about the impact of the program on the foster care population. But next slide, please. One of the points I think that was the most crucial for us is an emphasis on ongoing stakeholder engagement, that we spent a lot of time agonizing over our criteria to flag kids for review and our process of doing the review. But equally important is to engage important stakeholders in the community. For us, that included consumers, leadership in the community provider in different parts of our state, leadership from child serving agencies, and from health experts. This really had to be a community effort to improve safe and appropriate care. Next slide, please. Common issues that we talk about on a day-to-day basis with provider, we have started to appreciate more and more how common lapses are in medication adherence. We will sometimes get requests for very high-dose medication, but on our end, there's no evidence that the prescription's been filled for a few months. Even though we focus on antipsychotic medicine, we have engaged other experts and talk with Medicaid about concerns about high doses of co-prescribed medications. That's been most commonly related to treatment with stimulant medicines as well as alpha agonists. We do have referrals for kids where their first intervention is an antipsychotic medicine. So we may talk to them about behavior management resources, about other first-line medications first. And we also talk to them about, for ones that are approved for antipsychotic medicine, we do talk about which medicine that they're selecting. Sometimes the provider will pick a medicine that has worked great in an adult patient but really doesn't have any FDA approvals for uses in kids, so then we might think about, do you want to try something else first? And again, we try to frame all these discussions in a very collaborative, collegial way. Next slide, please. And I just want to acknowledge it really takes a village to develop one of these programs, and we've really benefited from a strong interprofessional review team, particularly acknowledge Ray Love and Heidi Waring, who lead our team of pharmacists, and also Dr. Lisa Burgess, who's our child psychiatrist from Medicaid, who we meet with on a weekly basis. And so at this point, I'm going to turn over to Susan. Oh, sorry, next slide. But before I do, I just want to mention that I think for anybody who's trying to initiate efforts to improve safety monitoring, common issues that we talk to providers with on a day-to-day basis is really dealing with needle phobia concerns. Sometimes we've talked to providers where a child requires sedation in order to get a blood draw. So those can be really challenging cases. We also know that some providers have less experience than others about what to do with abnormal labs and things that they're not used to monitoring. So for example, if we have a provider who's a mental health provider and they have a child with very high blood sugar level or elevated triglycerides, we can help them talk through how to get resources to address those concerns. Similarly, we provide information and resource support related to other side effects, including concerns about EKG changes or involuntary movements. Next slide, please. And now I'm going to turn over to Susan.
Great, thank you, Gloria. I'm going to take for the remainder of the presentation, talk about some of the academic research that's been done around monitoring psychotropic medication use among youth in foster care, and also include a little bit of what we've been doing to also incorporate the consumer perspective in the work that we're doing here in Maryland. So next slide. The information that I'll be presenting here, we call it our outcomes assessment. It's specific to children who are in foster care, and it reflects a true partnership between our Child Welfare Department and also the Behavioral Health Services Administration, in that there was an interest in really bringing together administrative records from both child-serving agencies so that we could really look at psychotropic use in the child foster care population. So that means merging information around the child placement, when they entered foster care, different placements that they may have had over that period of time. And we merged that with the medications based on the dispensing and where the child was at that point in time in their foster care experience. So what I'll be presenting is basically time trends, and they're broken down by therapeutic class and year. And I've stratified the graphs according to the child's age so that it would mirror the implementation of the pre-authorization program. Next slide. So in the first graph here, and I'll just orient you to this graph, the next two graphs will be the similar format. So what we're looking at here along the x-axis is just the monthly data. And we looked at the proportion. These are rates, the percent of children less than 5 years old who were in foster care. So within a given month, we looked at who was in foster care, and we also then looked at the number of children who received a psychotropic medication, and we have it broken down by whether there were medications for the management of ADHD, so they would be stimulants, and we also included atamoxetine. Whether they received a medication from the class of antidepressants, antipsychotics. We tracked whether the children were getting 3 or more classes, and then we also looked at mood stabilizer use. So then you see these red arrows, and the red arrows actually indicate when the prior authorization program was rolled out and which age range it impacted. So in October of 2011, we rolled out the prior authorization program for children less than 5 years old. In July of 2012, the age range was increased to those children less than 10. And then more recently, about a year ago, September, October, November, and December of 2013, you see it was expanded incrementally to 10-year-olds, 11, 12 to 13, and 14 to 15-year-olds. So if you look at this graph here, what you see is these are age cohort trends. So in January 2010, we looked at children less than 5 years old. And so this is basically that cohort over time, and as we move down the x-axis, they are aging, right? So by the time it was October of 2011, these children who were 0 to 5 in 2010 were now basically 4 to 6 years old. And so when the program was implemented in October of 2011, many of those children may have aged out, so they didn't really meet those criteria. And you can see that the green line, the antipsychotic line, there was very little change from that implementation. If we go on to the next slide, this here is now reflecting children, again, 5 to 9 years old, starting their age clock in January 2010. And what we see is that for those children, by the time the July 2012 prior authorization program was implemented for kids under 10, these are kids that are in the age range of 7 to 11. So now you see after that implementation, you see a slight drop in the utilization of the antipsychotics for kids in foster care. If you move further down the x-axis to our implementation for the older kids, they were now 8 to 12 years old, and you see also a subsequent decrease in the utilization of the antipsychotics. And I think what's interesting to note is we see that there was a gradual increase over time that has either stabilized and then decreased after the implementation of the prior authorization program. If you go to the next slide, which reflects our older kids, the older adolescents, older children, 10 to 14 years old. And this program really didn't impact these youth until 2013. And so you see obviously a little bit of fluctuation, but you see a more dramatic drop in antipsychotic use for these children in the September through December of 2013, which is when these children would be about 13, 14, and 15 years old. So taken together, we're seeing slight changes in antipsychotic use that were corresponding by age group, that were corresponding when the prior authorization program was implemented. So we can go on to the next slide. So one of the things that that does become important, and it goes back to an earlier slide that Gloria presented around the stakeholder engagement, is that the focus a lot for these programs to monitor psychotropic use for kids is really focused on the prescribing side of things, and working with prescribers around either changing or altering these regimens. And the one stakeholder that's on the receiving end of this is the family, the caregiver, and the consumers, and the children. And so, there's acknowledgement that that these youth have serious mental illness, and that they're commonly not just treated with one modality. And so, how do we work with our consumers to help them manage children with these serious conditions? And so I want to take the opportunity to share just some of the work that both Gloria and I are doing that really support these families. So next slide. The first is the Family Voice Study, and Gloria received funding from the Patient-Centered Outcomes Research Institute to essentially implement a randomized trial of a family navigation versus usual care. And this program is essentially targeting children less than 13 years old who have been approved for an antipsychotic treatment through the prior authorization program. And then family navigators reach out to these families and provide support for families who have children that are medicated with antipsychotic medication. And one of the things that that is truly important about this program is having a parent-to-parent support model. So when you have a program that could potentially restrict access to a medication, this program really kind of comes in the background to really help families, to support families in managing the needs of their children. And so acknowledging that that it's often difficult for caregivers, and they face challenges when things become restricted in their child's treatment plan. So next slide. And the other study that I wanted to highlight is the Pioneer study. And so, and this is also a study that was funded through the Patient-Centered Outcomes Research Institute. I received this funding early in 2014, so we're really just kind of getting underway with this. And essentially, we're targeting children who have intellectual disability as well as a mental health diagnosis. The proportion, the rate of aggression and irritability in this population of children is quite high, and they're typically treated with antipsychotics to manage the aggression. And so we're acknowledging that while we're looking at oversight and monitoring of psychotropics and antipsychotics in particular, and families often are not that keen on using these medications for their children, but they often feel like they have no other choice. And so what we're trying to learn from this work is how families are selecting and prioritizing treatment and outcomes and weighing the benefit risk of using or not using a particular treatment, and particularly medication, so that we can learn a little bit about kind of what families' needs are, what those goals are that they're striving for, and see how we can kind of embed that in shared decision making with the hope that these consults will really embed kind of the consumer and the provider in the treatment decision. So we wanted to kind of leave you with a little bit of that as the tail end, that we're thinking, not just about kind of the process for prior authorization, but we're really thinking about kind of the family experience. And I think with that, we can go next slide. Again, thanks for the opportunity to share our experience here in Maryland, and would be happy to entertain any questions from the audience at this time.
It looks like there is a question about the funding for the program. So in Maryland, the peer review program is a Medicaid program. So that's in the our state Medicaid budget, and then our team that does the clinical review, we're at University of Maryland in the School of Pharmacy and School of Medicine. So we have a contract with Medicaid to do those reviews. I don't know, Dr. Busch, if you wanted to comment in your state about funding.
Yeah, I saw that question as well. And in Wyoming, this is again paid for out of our Medicaid budget, out of state with state general funds.
Okay, so we also have a question, I think specifically for Maryland. Do you have any data looking at the outcomes of children, clinical, functional status, school status, family success, et cetera, as the rate of psychotropic prescribing has declined? What psychosocial interventions have been implemented as medication prescribing has decreased?
Okay. Yes, it's a great question about outcomes information. So part of what's happened in our process, so we started this program, or Medicaid started this program doing reviews in October 2011, first with just the preschoolers, and then we enrolled in the next year youth under the age of 10, and then the following year enrolled in the teenagers. So we really have been doing the groundwork process of really educating providers, getting started, and doing the reviews. So we are looking at information just to inform, from a quality assurance perspective, and also we get that question a lot from providers to be able to look at outcomes. I can tell you from my perspective as a reviewer, when we first started the program and we were enrolling in existing kids, the first 50 that we reviewed, there was no evidence that the child had ever had any lab monitoring done. These were our younger kids. When we were initially enrolling kids in the safety monitoring, that's probably where we've seen the most change. I would say we've gone from less than 10% of kids having any labs when they submit the initial paperwork to now we're getting much closer to I would say like 50 to 60% have some kind of baseline lab. So we are seeing changes, but for us to look at that systematically, that's not part of our Medicaid budget. So that's why we want to emphasize sort of this partnership with academic centers, is to also bring in other expertise to look at outcomes. I think Susan has some comments specifically on outcomes from the foster care population, but I can comment on the PCORI study, the Family Voice, where we're offering resources to families through this Family Navigator program. And one of the things that is striking to me is that we are spending a lot of time talking about different therapy treatments and therapy resources in the community. And the pushback we're getting from families is, that's nice, but I'm dealing with day-to-day living issues. I don't have stable housing. I don't have money to feed my kids. I don't have money to buy a school uniform this year. Or families who are overwhelmed dealing with mental illness of multiple family members all at once, and a lot of appointment burdens and other things. And so one of the things we're trying to learn from this more consumer-engaged research is how to really listen to families where they're at and think about, beyond traditional mental health services, what are their needs that greatly impact the functioning of that child and the family. And even though families may be eligible for a lot of resources through Medicaid and other programs, a lot of times when we talk to families, they're quite isolated and they don't seek it out because they're overwhelmed and stressed out with different issues. So we're hoping from these studies funded from PCORI that we'll have a story to tell in terms of what we're learning from consumers. Susan, did you want to comment on outcomes?
Yeah, I mean, I think, Kamala, one comment that you specifically raised from that question was around the outcomes related to the stability of these children and some of the other service utilization. So we have begun to do some targeted analyses to look at children who initiate an antipsychotic treatment, whether that corresponds with placement stability or looking at time to placement change. And so we've been collecting the data since it goes back to 2009, and Right now we have up through about June or July of 2014. So some of the data that we're collecting kind of is in a timely fashion, so it overlaps with the implementation of the program. We haven't been able to narrow down specifically the time points related to when the prior authorization was implemented, but we are looking at things like the placement stability, looking at occurrence of hospitalizations and ED visits for youth treated with antipsychotics. We're looking at patterns of medication use prior to the initiation of an antipsychotic, and specifically trying to see, and some of these data would predate when the program was implemented, so we have actually a nice baseline of the treatment patterns that we can then kind of going forward have more definitive data on some of the impact of this program. But what's interesting is to learn whether some of these children are kind of gradually increasing up to an antipsychotic, meaning that they have had a trial of a lot of different medications before the antipsychotic is initiated, or whether the antipsychotic is really the first medication used. And those, I think, are some of the issues and the red flags that are being captured now in the program. And so those are the kind of things that we're able to look at by having the data monitoring for kids in foster care. I hope that answers the question from the audience.
Thank you both for that. I have another question. You talked about the availability of the review process during normal business hours. And so I just had a question about what the process is if a request is received outside of normal business hours.
So the provider has a couple options if there is a need for immediate medication. So one of the things that Medicaid has set up is that a provider or family can request an emergency 72-hour supply of medications. And that could be either because it's outside of our business hours or they haven't completed the review yet, that sort of thing. In our state, kids who are under emergency care settings or intensive care settings like inpatient unit, the billing is bundled in a way such that obviously it won't affect a child's ability to get medication when they're in the hospital because they won't get a denial like someone would an outpatient at the point of sale. So we certainly educate and inform providers about the emergency 72-hour supply as an option to bridge if there's a gap in when they can contact us and there's an urgent concern.
Thank you for that clarification. That's helpful. We have other questions, specifically in the Maryland presentation, you called it out in your graphic around partnerships and stakeholders. But one question is specifically about how Wyoming rolled out the project to providers who are prescribing medication. And so I'd ask Dr. Busch if he would answer that and then also turn to Drs. Dos-Reyes and Reeves to answer that question as well. Dr. Busch?
Yes, I'm sorry. Could you repeat the question for me?
It's a question about how you rolled out the Red Flags program to providers who are prescribing psychotropic medication.
That was a very important step. So first thing I did was I went to our P&T committee and our physicians advisory group, which had first raised the concern. Then armed with that, I went to the Wyoming Medical Society and to our state psychiatric association, gave them our numbers, our needs assessment, invited them to participate in the program, but they all had no extra time to give to the program, so I got their blessings on the program. And then we rolled it out through, I went and spoke to the medical society meetings, hospital grand rounds. We did mailings and flyers. The psychiatrists from Seattle came out, and they continue to come out on a routine point going around the state and doing that. Plus, our case management provider for Medicaid has been promoting that as well. And anytime we have any patient or any concerns on the client, those are the ones that we also keep referring them into the program. So a very comprehensive program, but getting that support was crucial at the beginning.
Okay. This is Gloria from Maryland. So I think our process was actually quite similar. We approached the professional societies, so in psychiatry, in child psychiatry, and pediatrics, and gave presentations. And then we really sat down and talked about who were the largest service providers in our state, and spent a lot of time going to staff meetings at those kind of programs. We went around to school systems that treated kids with very serious mental illness. So we went to residential school programs, day programs. So we just spent a lot of time meeting with different folks. And the one thing I would emphasize, though, we did spend time talking to consumer groups, and I think that's absolutely critical in engaging your stakeholders to really go out to consumers, make sure people understand about the information. But that said, I will say, you know, change is difficult, and anything that requires time added another process, a time-consuming process. There are a lot of providers who were very resistant at the beginning to the program. So I think the outreach happens at the beginning just to give people an idea of what's coming, but it needs to be done in an ongoing way as you reassess the program, to get feedback, and to make sure that folks know how to utilize the program and interface with us efficiently.
Gloria, Camel, I just want to ask you to dive in just a little bit on the consumer piece. So certainly the providers, there are associations that people are probably familiar with, but can you just give us a sense of how you engage that consumer community, whether there were certain organizations that you reached out to?
Mm-hmm. Yeah, so we were, in Maryland, we were very fortunate to have an established partnership with the Maryland Coalition of Families for Children's Mental Health. Working with the Maryland Coalition was very helpful because they provide support and resources throughout the state of Maryland. And they also are, it's very helpful to engage a consumer group that's actively involved in advocacy work. So they were very familiar with talking to legislators about funding for different mental health programs and things like that. So it wasn't just to meet with them to inform them about the program, but to ask for their feedback and ask for their support, because they already were a strong voice in our state and a voice that our child-serving agencies really listen to, as well as legislators and community providers. One of the things that was sort of interesting when we went in this process of meeting with families, I showed the slide with the list of antipsychotic medicines, and I was struck by very often when I would present that slide, a parent would call out in the audience, you know, what do you mean that's an antipsychotic medicine? So a lot of times parents, even though they've spent a lot of time with their provider and probably got a lot of education about the medicine, when your child's in crisis, it can be hard to take all that information in. And I often had remarks from parents afterwards, oh, I thought that was a medicine for ADHD, or I thought that was an antidepressant medicine. So a lot of it was also an opportunity to provide outreach and education to families about some basics on medications, on safety monitoring, and on non-medication resources in the community.
Thank you, Gloria. I want to go back for a moment because I think we had an opportunity to hear from Maryland on this point, but did not ask this question to Dr. Busch for the benefit of the audience. So Susan talked a little bit about the placement stability, Dr. Busch, and their ongoing efforts to try to determine the impact that the prior auth has on placement. Can you say a little bit about whether you've been tracking placement stability in Wyoming? And the other thing I'd like you to speak to just for a moment is the total health record, because you did mention that during your presentation, and I know probably not all of our audience knows what a wonderful resource that is that you have there.
Great, thank you. Yes, we have partnered again with our Department of Family Services, so we were able to track all the children that we had these interventions on. And we are happy to report that they've remained very stable. There has not been any decompensation. They remain in a less restrictive environment on lower doses of medications. So the children appear to have done very, very well with these interventions. The state of Wyoming, when we were deciding to, this was prior to the ERA High-Tech Act, We were trying to consolidate all of our various databases into a single clinical database for the department's purpose, but the state agreed that it would be most cost-effective because we only at that time had about 20% of our providers on electronic health record. So when we went out and procured an electronic health record, we made it available to all providers who chose to use it at no cost. So it's a web-based EHR that meets all O&C certifications. We basically rebranded MIE's Web Chart Now. We've also made a personal health record available at no cost to providers, and combining them, we had a health information exchange, which was one of our initial purposes, so we can consolidate all of our databases in the Department of Health so every client will have all their data in this single database. And that's where we pull our CCD from, our continuity of care document.
Thank you, Dr. Busch. So at this point, I would like to end our formal question and answer period. I was remiss in leading into the Maryland presentation of not reading the bios for Dr. Dos-Reis and Dr. Reeves, but just very briefly, people probably have a good sense of where they're coming from, but I just want to state briefly that Dr. Dos-Reis is an associate professor in the Department of Pharmaceutical Health Services Research at the University of Maryland School of Pharmacy, and Dr. Reeves is an associate professor at the University of Maryland School of Medicine in a division of child and adolescent psychiatry. So I apologize for that on the front end. What I'd like to do now is shift gears and move into our brief discussion of technical assistance resources that are available. But before I do that, I just want to let folks know that another state that's done quite a bit of work in this area is the state of Arizona. And they have given us a lot of thought. In Arizona, Medicaid, child welfare, and behavioral health authorities are collaborating and have been very closely to put a program in place to improve the oversight and monitoring of psychotropic medications. And while we weren't able to include them on today's session just due to time, primarily time constraints, we've asked them to put together a short presentation that we will post alongside the Wyoming and Maryland presentations from today's session. So look for those in the next couple of weeks. So turning to technical assistance resources, I just wanted to very briefly call out for folks a number of resources that we've made available on our website through our work with the 6-State Psychotropic Medication Quality Improvement Collaborative. And so if you go to the CHCS website, and I think if you search on psychotropic medications and foster care, the webinar series that we're in right now will come up. That'll be available to you, but there are also a number of resources. We have a matrix that describes key features of several psychiatric consultation programs across the country. We have a matrix that lays out clinical and functional well-being assessments that states could adopt. We have a matrix that lists resources that are available to educate youth, families, child welfare staff, and providers, specifically about psychotropic medications. We have a technical assistance tool that describes the various approaches to agency consent for psychotropic medications. If you were on with us during the early part of this series, we had a webinar where we talked about, whether their state is responsible, the state agency, child welfare agency is responsible, or parents remain responsible for giving consent. And so there's some deeper information around that. Most recently, we posted a piece that looked at the states that have psychotropic medication prior authorization programs, as Maryland just described there. So there's some more information on additional states available there. And then finally, we have a document that goes into more detail around the data definitions that our data subgroup developed. So when I talked earlier in the presentation about our 6 states having decided on age 6 or below age 6 as being too young, there are a number of other parameters as well that are outlined in those data definitions that states could adopt. So there's a wealth of resources available there on the website with support from the Casey Foundation. So once again, thank you to Casey for that support. And what I'd like to do now is turn to Dr. Christopher Belanti, who's our senior clinical consultant for our psychotropic medication projects, and ask him to say a little bit about the SAMHSA-supported work that he's doing under the Technical Assistance Network, of which CHCS is one of 9 core partners. So with that, Christopher?
Thank you, Kamala. So I'm not sure how many people are familiar with SAMHSA, the Substance Abuse and Mental Health Services Administration Center for Mental Health Services TA network. The TA network is housed at the University of Maryland and can be accessed through their website, tanetwork at ssw.umaryland.edu. And we just completed a 3-part webinar series on early interventions for psychosis, which seems pertinent to this conversation about antipsychotic medications. And next up will be a 3-part series on working with youth that have co-occurring disorders and substance use disorders, so mental health and substance use combined. And that's going to be featuring folks from Case Western Reserve University. So the first webinar will be on prevalence screening and assessment on November 4th, 2 to 3:30 p.m. Eastern Time. The second is on treatments that work, scheduled for November 19th. And the third will be implementation challenges and opportunities that will be co-presented with partners from system of care sites that have implemented some of the suggested interventions for this population. So I just want to put in a plug for folks to enroll in the TA Network site. You don't have to be a funded system of care community in order to be able to benefit from this clinical distance learning series that we're offering through SAMHSA.
Thank you, Christopher. So what I think we would like to do at this point is begin to wrap up. This is, as I said at the outset, the last webinar that we have scheduled for the year. What you'll see on your screens now are what we hope are some of the takeaways, some of the information you gleaned from today's session that you can take home, that you can discuss with your colleagues, and potentially think about how you might be able to improve the systems you already have in place in your states. And if you don't have oversight and monitoring systems in place, some of the things to think about to inform those processes. So what I would like to do at this point is thank Casey again for their support, and specifically Tammy Fleming and John Hodkins, who has been our collaborator in this webinar series. Thank you very much. The slides and the video archive will be available on the website pretty much by the close of business tomorrow, most likely, for today's webinar. And as I mentioned earlier, if you go to www.chcs.org and you do a search for foster care and psychotropic medications webinars, it'll bring you to the website that has all of the webinars posted, and then there are links to the resources that I mentioned. And finally, as we end, we'd like to ask that you complete the survey that's going to pop up when the webinar ends. There are only a few questions, and as always, your feedback is important. It helps us think about how we can best meet your needs through virtual means such as this. So with that, we're going to conclude for today and wish everyone the best. Thank you.